This is part two of inflammatory drugs. In this presentation, we're focusing on anti-gout and uricosuric agents, as well as drugs for arthritis. And we'll start with drugs for gout. So gout is not just about bones and joints, but interestingly, when there is a higher uric acid level, there is an increased risk of hypertension as well as cardiovascular risks. And the dietary approaches to stop hypertension diet, or the DASH diet, not only helps in heart disease, but is also helpful in gout. We used to have patients following a gout diet, but that's not really supported by evidence. Increasing fluid intake does seem to help. We have at our disposal the anti-gout drugs that actually reduce the inflammatory process, or they play a role in the synthesis of uric acid, and then the uricosuric agents that increase the rate of uric acid excretion. Allopurinol and febuxostat inhibit xanthine oxidase and thus are called xanthine oxidase inhibitors. And that's the enzyme that's responsible for conversion of hypoxanthine and xanthine to uric acid. So both allopurinol and febuxostat actually can decrease the production of uric acid without actually disrupting the biosynthesis of vital purines needed in the body. Allopurinol acts directly on purine metabolism. The serum and urine uric acid starts to fall within 2 to 3 days. And this can actually be used off-label for prevention of renal calculi. It can help prevent calcium oxalate stones. Febuxostat also inhibits xanthine oxidase, but it may take about 2 weeks to see the effects. So these xanthine oxidase inhibitors can help patients with gout by inhibiting inflammation, preventing synthesis of uric acid without disrupting the biosynthesis of vital purines, as I mentioned in the previous slide. And we aim to get a serum uric acid level of less than 6. And patients that are put on allopurinol, initially with the extreme pain that they have, will need inflammatory agents such as indocin or steroids. Indocin would be an issue if patients have advanced renal disease, so steroids may be used instead, though there may be issues with steroids as well. Colchicine does not actually impact purine metabolism, but it can inhibit the migration of granulocytes to the inflamed area, so it reduces deposition of uric acid. So it has anti-inflammatory effects, it can reduce pain, and it's the time-honored one used for acute attacks. You can also use the NSAIDs and steroids, but often they often will be added to colchicine because patients can't always tolerate the side effects of colchicine. So they may need lower doses or be taken off colchicine if they can't tolerate side effects. Colchicine can also be used for prophylaxis, and there is an available transdermal formulation. The uricosuric drugs, as I mentioned earlier, increase the rate of uric acid excretion. We have probenecid, which does not really have any inflammatory effect, and then we have pegloticase, which is actually a parenteral drug, and lesinurad. These impact uric acid excretion or can change it into uric acid into inert substances that don't get deposited. So the deposits in general are reduced and deposition is slowed, and they can promote the reabsorption of urate deposits. These are not to be used as monotherapy, so they may be used in combination with other drugs. So some considerations for gout medications, adverse drug reactions. They're not to be used in children or pregnancy unless you have a child who has a uricemia of malignancy, then they may be used there. They can be used for stone prevention, as I mentioned, allopurinol, but uric acid crystals, when mobilized, can precipitate renal stones. So, uh, you know, that's something that we need to keep in mind. GI disturbances are common, and so peptic ulcers need to be monitored. Probenecid is actually a sulfa-based drug, and so there may be a hypersensitivity reaction in patients that are allergic to sulfa. You can also get a hypersensitivity reaction that occurs more often in blacks and Hispanics with allopurinol. And colchicine can cause myopathy, weakness, neuropathy, and problems with malabsorption of B12. Febuxostat, we need to watch liver function abnormalities. And then plagoticase and lesinurad can actually have been linked to major cardiovascular events, but more research needs to be done along those lines. So other considerations, uric acid is more toxic to older adults. Older adults seem to do better with probenecid as the drug of choice. All of the drugs need to be used with caution in patients that have renal impairment. And so probenecid may work better for older adults who tend to have more problems with renal impairment. And they're more likely to become toxic when used in combination with thiazides. Off-label uses of anti-gout drugs include allopurinol, which, as I mentioned, can be used to prevent renal calculi from calcium oxalate stones, and colchicine, which can be used for a variety of things, as you see here. I was not familiar with familial Mediterranean fever, but that is a hereditary inflammatory disorder. Now we move to osteoarthritis drugs. So osteoarthritis is one of the most common complaints that we see in primary care and a big cause of disability. And there's actually loss of the cartilaginous bone surfaces, and you get that bone-on-bone situation. So pain relief is key to keep people mobilized, keep them active in their daily activities. And once they start getting into the chronic pain syndrome, they can spiral down pretty quickly in their functioning and in their productivity in society. Acetaminophen may be used initially because most chronic conditions of osteoarthritis are not actually inflammatory. We don't see the inflammatory changes in joints like inflammation, such as swelling and redness. That occurs occasionally, but for the most part, it's not considered an inflammatory arthritis like rheumatoid arthritis is. So that's why acetaminophen can be helpful early on. And again, since pain can be chronic, we try to get people to take acetaminophen, hope that it works before we get into NSAIDs and other treatments, just because of the chronicity of it and the concern about all the side effects from NSAIDs. So when there is, osteoarthritis tends to be a kind of waxing and waning kind of condition where people get flare-ups, sometimes for a few days, sometimes for a few weeks, and then they seem to get better. In those times, we can use NSAIDs. So a little bit more about acetaminophen. It is more of an analgesic and antipyretic. It's not anti-inflammatory. The mechanism of action is not well known, although it's thought to work on prostaglandin synthesis. It can reduce fever. It does not affect COX, so we don't have to be concerned about platelet aggregation or GI irritation. So if you use topical site-specific agents, like some of the over-the-counter topicals in conjunction with acetaminophen, there may be a better outcome. Um, it does work in usually fairly well in studies. It has shown that moderate levels of pain, but not much. Doesn't do much for severe pain. And there are some hepatic concerns, especially if the patient is taking other drugs that affect liver. Adverse reactions, you can have acute hepatic necrosis in doses of 10 to 15. Above 25 grams, they're usually fatal. And there is an antidote that's a mucolytic, N-acetylcysteine, that is used for in the hospital for acetaminophen toxicity. Clinical uses can be used in pregnancy and in children and patients that have a history of GI bleed and have aspirin allergies or GI problems. We definitely want to avoid using NSAIDs in aspirin in children. So it does work well for fever in those folks. NSAIDs, I'm going to say just a little bit about them. Actually, I'm not going to say much at all because we already had that well discussed. But to mention that there are some topical NSAIDs such as Voltaren. Actually, Voltaren name is no longer on the market, but it is diclofenac. Works very well in the oral form, but also can be somewhat helpful in the topical form. So patients that have GI problems or intolerance to taking NSAIDs can try topicals. Glucosamine is an alternative that is considered a supplement. Not a whole lot is known because it is a supplement, so it's not subject to the rigorous FDA studies that need to be done before it comes on the market. It can take months to see a full effect. Some patients really swear by it. Some say it doesn't really do much at all. It is an anti-inflammatory, or thought to be an anti-inflammatory that is safer than NSAIDs. And it can be mixed with COX-2 inhibitors to help reduce stiffness and pain. So generally, what I've heard from patients is that the stiffness is what they seem to notice. It may help pain as well, but again, it's really individual. As I said, we don't really have much really good research indicating, that it's that useful, but it's probably something that doesn't cause much harm, so it could be tried. We can use arthritis, steroid injections for arthritis, in particular joints. And these injections usually work fairly well. Generally, they can give injections about every 3 months. There is, of course, the risk of infection because you are suppressing the immune system locally. There's also, of course, the introduction of contaminants that can cause infection. So osteomyelitis is certainly a major concern. And as I mentioned, patients can get about 4 injections per year. So that's something that can be tried in addition to other treatments such as PT and oral medications. Weight loss is a big deal. We're seeing so many more knee replacements, hip replacements, etc. Because, they're so common because the materials we have are so much better, the techniques are so much better, but also because people are so much more overweight, and that certainly contributes to joint degeneration. There are also the non-steroid injections such as Synvisc, and these can work really well. Generally, you see people not getting authorization for those unless they've tried some steroid injections, but these may also be something to do before joint replacement. Now we'll move on to rheumatoid arthritis agents. And as I mentioned, rheumatoid arthritis is highly inflammatory. So you do see a lot of joint swelling and erythema, bone loss. There's also a heightened immune response associated with an overproduction of tumor necrosis factor, and that's one of the ways it can be approached in treatment. But it also impacts many other organs, especially pulmonary and pleural cavities, causing, like pleural inflammation. You can have keratoconjunctivitis, pericarditis, and vasculitis, to name a few. So patients will also have constitutional symptoms of fatigue and lethargy, maybe even change in appetite, muscle pain. They may even have low-grade fevers when it's more in a more inflammatory state. Um, you don't want to start. Chronic pain is a real problem with these patients, but you don't want to start opioid use because opioids don't really work well, and we know all the problems associated with opioids at this point. So the approach is that you want to be somewhat aggressive. You want to consider disease-modifying anti-rheumatic drugs earlier rather than later. And these are prescribed by specialists. So the introduction of DMARDs, or disease-modifying anti-rheumatic drugs, and biologics has really revolutionized the prognosis and the longevity of patients. So early use can do exactly what they say, modify the disease so that it doesn't progress as quickly. In the past, we used a lot of steroids to relieve pain and inflammation, but the long-term consequences of using those drugs is much less desirable. And so we, evaluate when we're going to use the steroids. Usually, what I see is that they may be started early on at the time of diagnosis, but then other drugs in the DMARD category will then be initiated. Minocycline is something that may be tried, and we also still see patients on gold salts, D-penicillinase, azathioprine, and cyclosporine are also used in some patients. But more commonly, we're seeing the DMARDs, which are categorized as either non-biologicals or biologicals. So this lists all the drug classes. Minocycline may be classified as a DMARD. The non-biologicals include methotrexate, Plaquenil, and the JAK inhibitors, which we'll get to. The biologics include the TNF alpha-1 inhibitors, Enbrel, Remicade, and Humira, and the non-TNF biologics such as Rituxan and Orencia. And then the biosimilars, that's another classification unto its own, which I'll talk about, and those are the newest. Minocycline is in the tetracycline family. It's not really known how it works. It can help with early mild disease to reduce pain in the tender joints. Photodermatitis is always a concern. In other words, if patients are exposed to sun, they can get sunburn pretty easily. There are lots of drugs that cause photodermatitis, and they're not used in the second half of pregnancy because they can stain the teeth of the fetus. Methotrexate is a good early choice. It inhibits cytokine activity and production of purine, and the anti-inflammatory effect takes about 6 weeks. You can increase doses as well as switching from oral to IM dosing. It can be mixed with other DMARDs, and it is not used in pregnancy. ADRs are listed here. We do have to be concerned about GI effects. Still also need to monitor kidney and liver function as well as platelet function. And it is excreted in the urine, so it's recommended that you wash urine-contaminated clothing separately. Plaquenil is a non-biological quinolone that's used and can be used in combination with other meds, and I've seen it initially used by itself as well. It does not cause the bone marrow suppression like others in the group. It can cause deposits in the cornea, and degeneration of the retina. And so it's very important that patients have yearly eye exams. It's also used as an anti-malarial. The Janus kinase inhibitors, or JAK-inhibs as they are called, is a family of intracellular tyrosine kinases that can provide transmission signals from cytokine, interferons, and some hormone receptors to the nucleus, which results in a synthesis of many biologically active compounds. The JAK inhibitors basically inhibit cytokinase. It can be combined with other DMARDs, um, and can be given orally or parenterally. They can help. This can help. They can help with bone erosion. May not decrease the synovitis, but it can increase the risk of infection. An example of this is Xeljanz, which I know you have seen advertised a lot. Okay, biologicals. There's a lot of direct-to-patient advertising that has made some patients believe that these are the answer to their problems. However, there a lot of people are much more conservative and want to go with other DMARDs before going on to using these drugs. But on the other hand, specialists are the ones who actually infuse them in their offices. Those are the physicians who actually dispense and prescribe them, and they're a big moneymaker. So that probably has a lot to do with why they've been used so readily. But they're generally initiated after failure of the non-biologicals and progression from moderate to more severe rheumatoid arthritis. And they include two classes, the TNF alpha-1 inhibitors, which are Enbrel, Remicade, and Humira, and the non-TNF inhibitors, Orencia and Rituxan. So they have strong immunosuppressive properties, which is also an area of concern in terms of adverse reactions. There's potential for sepsis, development of lymphoma, leukemia, melanoma. Patients that have had tuberculosis may not even know it, may have a reactivation of TB. Hepatitis B and fungal infections are also concerns. These are only prescribed by specialists, as I said. There are some that have subcutaneous injections, and there can be reactions at the site. They are manufactured with a gentamicin base, so patients that are allergic to gentamicin may also have a potential allergic response. The concerns, other concerns other than I already mentioned, is that you can have, with the TNF inhibitors, you cannot give live vaccinations because of the risk of immunosuppression, concern about cardiovascular and vascular diseases, and some post-infusion reactions that I have listed here. Then a couple words about the biosimilars. They are the newest classification of biologics, and they are supposed to have the same clinical endpoints as the biologics. They're not considered generic. They're not exactly the same molecule. They do not have the same structure or even chemical function. They don't meet the same efficacy requirements. They can only be used for the same FDA-approved indications. So biosimilars have the exact same name as the patented biologics